concepts of oncology. Subscribe to our channel for new cancer related videos every week. Germ cell tumors in body can occur at 3 sites, most commonly, testes, mediastinum, retroperitoneum. Extragonadal germ cell tumors can occur in 5% of cases. If we compare germ cell tumors of gonadal and extragonadal sites, seminimus in mediastinal, retroperitoneal and testicular site are equal in term of prognosis and treatment. However, in case of non-seminimus, retroperitoneal and testicular are equal in terms of prognosis. However, mediastinal non-seminimatous germ cell tumor are different. Germ cell tumors can be broadly classified into seminimus and non-seminimus. Non-seminimus are further classified into several types like embryonal cancer, yolk sac tumor, choriocarcinoma, teratoma, and mixed. Seminimus are the most common germ cell tumor. Among non-seminimus, mixed variety are most common. Primary mediastinal non-seminimatous germ cell tumors are different. They are less sensitive to chemotherapy, have poorer prognosis than retroperitoneal and testicular NSGCT, more likely to have yolk sac component. More elevation of alpha-fetoprotein is present, associated with Klinefelter syndrome, and associated with hematologic malignancies that carry extra copy of 12p chromosome. Seminoma is the most common germ cell tumor of testes. It occurs commonly at slightly higher age group than NSGCT. Usually tumor markers are not raised, however 15% cases may have raised HCG. Typically they are PLAP positive, placental alkaline phosphatase. Embryonal cancer is an aggressive tumor, as it is most undifferentiated. It has totipotent capacity, means it can convert to others' histologies. It also has high rate of metastasis. Choriocarcinoma has high HCG level. HCG hormones mimics LH and TSH hormone, thereby leading to hyperthyroidism and ovarian cysts due to stimulation. This tumor is prone to bleeding, which can be life-threatening, like bleeding in intracranial mets or visceral mets. There is high chances of blood-borne mets. In yolk sac tumor, AFP is raised, no rise of HCG, and is more common in mediastinal and pediatric germ cell tumor. Teratoma are unique in that it is derived from more than one germ cell layers. Well-differentiated teratoma are called mature teratomas. They typically are resistant to chemotherapy, hence if teratoma is present in lymph nodal mass, it may continue to grow despite chemotherapy and may attain large size, hence, called monster tumor. They are histologically benign, but genetically unstable. Any intratesticular mass, if firm to hard, must be considered to be testicular cancer, until proven otherwise. Once we have suspected case of GCT testes, tumor markers and serum are done. HCG, human chorionic gonadotropin. They are elevated in choriocarcinoma, embryonal cancer, and 15% case of seminoma. Half-life is 1 to 3 days. Alpha-fetoprotein is elevated in yolk sac tumor, teratoma, and embryonal cancer, with half-life of 5 to 7 days. Lactate dehydrogenase LDH is non-specific marker which signifies burden of disease. Along with tumor markers, high-resolution ultrasound of testes is done. If there is doubt in diagnosis of GCT and USG, then MRI testes may be done. However, in most situations USG can accurately diagnose GCT. With suspicion of GCT, high inguinal orchidectomy is done. USG can show homogeneous mass in case of seminimus or heterogeneous mass in case of NSGCT. Additional Doppler can reveal vascularity and mass. Transscrotal biopsy is contraindicated as it may lead to carriage of tumor cells from testes to scrotal wall. This will upstage tumor as well as increase chances of spread to inguinal lymph nodes, which are main drainage area for scrotal wall but not of testes. Inguinal incision is given with ligation of cord at deep ring. Some leave a long non-absorbable thread on patient side of cord which helps in identifying residual cord. If RPLND retroperitoneal lymph node dissection is planned at future date. Clinical staging of testes is done to plan treatment. Stage 1 is disease limited to testes. Stage 2 is regional node involvement. In case of testes, retroperitoneal nodes are regional nodes as testes embryologically develops from retroperitoneum. Hence, vascular supply, lymphatic drainage and nerve supplies from retroperitoneum. Stage 3 is distant mets or non-regional nodes like mediastinal or left supraclavicular or elsewhere. Investigations required for clinical staging are post-orchidectomy tumor markers, LDH, AFP, HCG, done after 1 week of inguinal orchidectomy. It is important to note that for staging of testes cancer post-orchidectomy markers are used, not pre-surgery. CT scan for retroperitoneum, imaging of chest X-ray or CT scan. In case of choriocarcinoma with very high HCG, brain MRI as indicated. FDG PET scan has no definite role at present in staging. Conventionally 1 cm criteria is used for diagnosing nodal mets in CT. However, this criteria may miss many small GCT mets, hence many radiologists in case of GCT may reduce cutoff to 6 to 7 mm. TNM staging of GCT testes is unique as it also includes serum markers. Hence, to be more correct, it must be called TNMS staging with S standing for post-orchidectomy serum markers, AFP, HCG, LDH. It is important to note that scrotal involvement is T4, hence scrotal route is avoided for biopsy. T0 indicates that situation in which there is nodal disease, but no testicular swelling. On USG there is no mass but a scar is present. This scar may indicate burnt out old cancer. If there is absolutely normal bilateral testes in case of nodal disease biopsy proven for GCT, then it may be case of extragonadal GCT. Clinical end staging is by CT scan. Pathological staging is done only if patient has undergone primary RPLND without any chemo or radiotherapy. In M staging, non-pulmonary mets have worse prognosis. S1 to S3 is based on extent of raised marker. Prognosis of NSGCT is based on markers at start of chemotherapy post-inguinal orchidectomy, non-pulmonary mets and primary mediastinal GCT, while prognosis of seminoma is based only on non-pulmonary visceral mets. In rest other conditions including lung mets, prognosis is excellent. There is risk classification for advanced GCT cases by the International Germ Cell Cancer Collaborative Group, IGCCCG. It is applicable only to advanced metastatic cases and not early GCT. It places patients of advanced GCT in 3 groups: good prognosis, intermediate prognosis and poor prognosis. Important to note that none of seminoma cases considered poor prognosis. Any 3 prognostic factors of NSGCT, discussed earlier, places NSGCT patients in poor group. Principles of GCT treatment. Aggressive approach is followed as there is chances of cure even with mets is possible. This is very rare scenario in cancer. Cure in mets. If markers are elevated then chemotherapy is given preferentially. RPLND is avoided with raised markers. If a patient comes with extensive symptomatic visceral disease with high marker levels, then such cases are provisionally diagnosed as GCT and can be directly started chemotherapy instead of inguinal orchidectomy, which can be done later. Hence patient who is in distress will immediately get benefit of chemo instead of waiting for biopsy report. Radiation has a limited role only in early seminoma as they are radiosensitive. After histopathology, post-orchidectomy serum tumor markers and imaging, clinical stage is defined. For clinical stage 1 NSGCT, disease is limited to testes, markers normalized after HIO, but there is risk of nodal micrometastasis, so patients are categorized as high risk or low risk of having micrometastasis. Based on presence of lymphovascular invasion and presence of embryonal cancer component in histology done after HIO, as these 2 risk factors increase chances of nodal mets in NSGCT. Low risk cases can be put on surveillance while high risk may be given some form of treatment, surgery, RPLND or chemotherapy. Those on surveillance if relapsed then bulk of relapse may decide whether to go for chemo or RPLND. In general, bulky disease is always given chemo and raised markers is also given chemo first. Stage 1S has persistent raised post-orchidectomy markers but no disease on imaging. Such cases are due to micromets, hence they are given chemo like stage 2C and 3. For stage 2A and B, there is nodal disease and retroperitoneum. Hence for less bulky disease with normal markers, RPLND is preferred, while with large more than 3 cm node or raised marker, chemo is preferred. It is also important to note that if there is suspicion of teratoma in nodes as there was teratoma component in testes tumor, then surgery would be preferred as teratoma do not respond to chemo. For stage 2C and 3, there is large bulk of nodal disease more than 5 cm or with non-regional mets or visceral mets. Such cases are given chemo. Using IGCCCG risk stratification in these advanced GCT, Number of chemo cycles may be decided with decreasing number of cycles in good prognostic group, thereby decreasing side effects without compromising on cure. CT scan is done in follow-up after chemo for nodal disease to look for residual masses. Post-chemo residual disease in retroperitoneum can be malignancy, necrosis or teratoma. Surgery can differentiate between all three. In case of NSGCT, any residual mass more than 1 cm requires surgery as there is chances of them harboring cancer cells or teratoma. In clinical stage 1 seminoma, there are 3 options with excellent result of all 3. Surveillance, chemo or radiotherapy. There is negligible chances of relapse in retroperitoneum if radiotherapy is given, hence such case do not require abdominopelvic CT scan. They would have relapse in chest, if any, hence they would require only markers and chest x-ray in follow-up. However, after chemo or surveillance, abdominopelvic CT scan is required regularly in follow-up along with chest x-ray and markers. Chemo is single agent carboplatin 1 or 2 cycles. It is sufficient. Radiotherapy covers retroperitoneum and ipsilateral iliac field, thereby called dog-leg field or hockey stick field due to its design. For clinical stage 2A and B, there are 2 options for nodal treatment, chemo and radio. There is no role of primary RPLND in seminoma. Again, for bulky disease, 3 cm, multiple site, chemo is preferred. For solitary or size less than 3 cm, radiation is given. Clinical stage 2C and 3 represents bulky disease or METs or non-regional nodes, hence these patients are kept on chemo. Post-chemotherapy scanning, if shows residual disease, cutoff for RPLND is 3 cm, disease less than 3 cm is followed. PET scan has a role in this scenario. PET positive mass are operated. Concepts of oncology. Subscribe to our channel for new cancer related videos every week.